My name is Tony Marisa. I direct the East Texas Geriatric Education Center. And this is the second session in the series that we are promoting and looking at maintaining independence as we age. It's a very important topic, and last month we looked at social isolation and the risk factors that can occur for isolation and risk of elder abuse. And we have a lot of resources with APS and guardianship. And that is available on video, as on YouTube, and as a DVD if anybody would like to see that. And we can talk about that later. But for today, we're going to be looking at adaptation and changes in lifestyle. I've always been amazed and fascinated by the ability to adapt to different environments for all animals. I remember us adapting after Hurricane Ike when all that was happening. So how does, as we age and have maybe declines in health and loss of friends and family, how do we adapt, and what are some of the risks of losing a relative independence if maybe adaptation is a little more difficult? And what are the options that might be available in intervention? This, by the way, is the mission for the ETGC. The important words are kind of underlined. We are very interprofessional. We focus on students, residents, health providers, fellows, lots of different disciplines. We've been doing this for a long time. And I think it's become something people look forward to in terms of the things we do. This is the agenda for today. We'll have 3 presentations by 3 very good speakers, many that I've known for a long time, looking at adaptation, aging in place, to be given by Andrew Word, driving retirement, looking at Dr. McGregor, and managing behavioral problems in elderly by Dr. Rodney. There'll be a short break. I don't know what you can do in 5 minutes, but maybe we can extend that if you really need it a little bit if we're running okay. This is the series. Like I said, we did social isolation. We're going to be taking March off because of spring break. And but we'll be back in April looking at health conditions that can affect independence, like incontinence, philosophy. We're looking at mobility, risk of falls. For that session, and you'll be hearing more about that. And in May, we're thinking about looking at surgery in the elderly, but we may be looking at some other topics, so we're working on that. So this is the purpose for this session, looking at the challenges that, like I mentioned, that older adults face to adapt to changes in lifestyle. And you'll be hearing much more about this in terms of coping mechanisms and how to assess whether adaptation risk for loss of independence is found. These are the learning objectives. We have quite a few. No, I think that's a record. I don't know. But this is the other thing. We are part of a consortium, so we broadcast to other sites within our consortium. Lamar University in Beaumont, Stephen at Boston and Nacogdoches, Baylor University in Waco, Victoria College in Victoria, and Weatherford College in Decatur. And they are on the monitor, and we're going to be bringing them up on the screen so that you can see who they are during discussion and help out with that. And so welcome to all our remote sites. Okay, we offer free CD credits. This is what we need from you to obtain continuing medicine education credits. These are the steps that you should have with all the paperwork, and Erica can help you with that in terms of what you need to do. It's an online credit request now, which is really nice. And there's evaluation forms and everything that you need. And so if you have any questions about this, just let me or Erica know about it. Okay. And we offer free continuing nursing education credits, RNs and LVNs. There is paperwork for how to achieve successfully complete paperwork to obtain the CNE. Just so you know, for CNE, you must be present for the entire 3-hour session to obtain the credits. And for all our CE, I need to let you know that our program planning committee members, as well as our speakers, have no commercial affiliations or relationships to disclose. It's official. We also offer CEUs for social work. There's a sign-in sheet for that, as well as a registration form, and just submit the general evaluation. Lots of paperwork, lots of details, but we offer it all in a detailed and healthy and also CE, physical therapy, and occupational therapy. So the URL and are now at their computers, at their PCs, loaded on with us. And at the end, at each session, we will have questions and a passcode that they can call in, and we will hear them coming through the speakers. Any questions so far? All right, our first speaker is Andrea Wirth. I've known her for a long time. She's a nurse, geriatric nurse practitioner in the Division of Geriatric Medicine. She works as an adult and geriatric nurse practitioner practicing in the Department of Internal Medicine, Division of Geriatrics. She's been doing this for 14 and a half years. Received her master's in at BSN here in nursing at UTMB and master's in nursing at UT Health Science Center in Houston. And she practices in the outpatient clinics in geriatrics and has been involved in the geriatric house call. She presented for us before when we've done geriatric assessment programs. And she can also conduct a monthly educational workshop for caregivers for those suffering from dementia. So I'd like to welcome Andrea Wirth.
Aging in place versus relocation. The objectives two are to define aging in place, to identify those age-related changes that can impact aging in place, review the functional assessments used to identify those deficits, review strategies that can facilitate aging in place, and then review some planning process that will take place should relocation be necessary. It can be defined as living in the place where you've lived for years. Also living in one's home or community safely, independently and comfortably, regardless of your age or income or even your ability level. Another definition that I found was to live in a non-healthcare environment using products, services, and conveniences without having to move to, regardless of the changing circumstances. We hear this aging in place often used for those in the senior marketing group who are talking about aging in place. And usually they're referring to a complex. So somebody would have to actually move to the complex and then age in place in that complex. So that would be a complex that would include independent living, assisted living, skilled nursing, long-term nursing, all in one place. So sometimes that's when we hear the words aging in place. So why is aging in place important? It seems sort of obvious for those of us who are taking care of elders. But I think what we hear most of the time from our elders is that they do want to age in place and have that control of where they're aging for a lot of these reasons. They want to be comfortable in their own environment. They want to have that continued independence, making decisions of how they do things every day, having the convenience of their community, the services in their community, things that are familiar. They feel safe, secure, in their own environment that they have been in probably for many years. And proximity to family, although sometimes we don't see proximity to family. Many family members have moved, and then that becomes more difficult for those family members. They would like them near them, then that's a whole nother transition that has to occur or has to be discussed. So what we probably need to then do is look at some age-related changes and conditions that can limit that success of aging in place. So here are some. Sensory, we know that age-related changes to vision do occur. So 90% of elders will need glasses. Pretty much nearsightedness is universal as we age. And 45% of elderly actually have the functional impairment related to vision losses. There's many common disorders and diseases in aging that will impact vision and thereby function. Cataracts, of course, are probably our most common, but then macular degeneration, glaucoma, diabetic retinopathy. These are all conditions that will limit vision and thereby function. Hearing, also very much a process that can change with age. We have the loss of the high frequency sounds. and then more difficulty with consonants, thereby making conversation a little more difficult. Almost 2/3 of those over the age of 70 have some hearing loss, and even up to 3/4 of elders over the age of 80 will have some loss. The hearing loss can lead to suspiciousness by those with hearing loss, maybe some withdrawal, isolation, depression, and even the perception of others of the elders having cognitive decline. So it really is an area that we need to address in order to ensure that they can maintain that function. Mental processes, while it's not normal to have dementia as we age, there is 20 to 50% of those over the age of 85 will have dementia. There are some slowing of retrieval and an increased time required to learn new materials as we age. And we know that people who have some of these cognitive losses, either early dementia, and as it progresses, there's going to be an association with an increased need of health services and also an increase in mortality. And of course, the caregiver burden that is involved in caring for individuals with cognitive losses. In the area of strength, some changes do occur in the integrity of bone. So we see an increased number of individuals with osteoporosis as they age, putting them at that risk for fractures and thereby a decrease in function. We also see a loss of muscle mass and strength, again, impacting mobility and function and increasing that fall risk. And then there are these chronic diseases that are very common as we age. The osteoarthritis, diabetes, hypertension, heart disease, all of which can cause some decrease in function, mobility, being able to age in their own environment without some things being done. So what do we do then with knowing these normal changes? Well, that's sort of major part of the geriatric assessment is to look at function. So that's we can do. And how do we do that? These are some of the functional assessments that can occur with an evaluation to really look at function and how an individual is going to be able to age in place or what kind of interventions would be needed. So the activities of daily living, the instrumental activities of daily living, some gait and balance assessments, shoulder function, hand function, the visual acuity and hearing acuity, and then cognitive function and mood. So the first, the activities of daily living, the CATS Index of Independence and Activities of Daily Living, a pretty simple questionnaire to look at these activities that are done by everyone every day. Feeding, going to the bathroom, transferring, toileting, dressing, and bathing. And it's a questionnaire of just asking the individual if they can do this by themselves, do they require assistance, or are they totally dependent upon another individual to accomplish these. 90% of individuals out there in the community are fairly independent or with minimal assist able to do these kinds of things. However, the instrumental activities of daily living are a little more involved. And so these are cooking, cleaning, doing laundry, shopping, using the telephone, transporting, driving, taking medications, and managing money. Transportation can also be buses and things like that. So then again, it's a questionnaire. Are you able to do it independently, to require assistance, or are you totally dependent upon others? And so a lot more individuals are involved in needing more assistance in these areas as they age. So this is, again, gives you an idea of how are they accomplishing it, asking who is helping you, how is it getting done? The next would be to evaluate mobility and strength. We know that there's this trajectory there at the top that if individuals are immobile, they can then become deconditioned, which then can lead to falls, which then can lead to institutionalization. So we're trying to make an impact here, do something to intervene in those steps. So we need to assess falls, gait and balance, and transfer. Falls, assessing how many have occurred, when do they occur, where do they occur, is it inside the house, what particular part of the house, outside the house, falling forward versus backwards,
Has it just started versus it was a long time ago? So just evaluating for that is important. The get up and go test is a relatively simple test to do to evaluate how a person stable they are with their gait and their balance and able to transfer. So basically it's having a person stand up from a chair. If they can do it without their hands is what your goal would be, but you ask them to stand there for a moment, walk 10 feet, turn around, come back to the chair, and then turn and sit down in the chair. So the idea being that you would assess then how is their gait, how are they able, is it even, unsteady, how are they able to turn, transfer without staggering. So we're looking at all of that when we're doing that simple test, and it doesn't take that long. The Tinetti balance and gait evaluation, a little more involved. It does look at the same things of the actual gait and balance. It's actually watching someone do the same sort of thing, but it's a little bit more involved. So that gives you an idea of how stable they're going to be. And of course you can see if they're using assistive devices when you first see an individual as well. Shoulder function is going to be important for being able to do a lot of those tasks in the house. So being able to have them show you their range of motion of their shoulders and if there's any pain affiliated with that range of motion that will limit them from using that. So you could ask them simply to put their hands behind their head or put their hands right here behind their back. And if they can't do this, it's going to really limit them to be able to get things out of cabinets, be able to pull things, to hold things. So that's going to limit what they're able to do in their own environment. Hand function, also the same thing. If you're not able to use your hands, how can you do a lot of these activities that I mentioned before? So a simple test to look at strength would be to actually grasp someone's hands and try to squeeze, but also the pinch test, looking at how much strength there is in fingers, just asking them to hold a piece of paper and then you try to pull that piece of paper away from them, and how easy is that for able to do. Because opening jars, opening doors is really affected with that function of the hands. The sensory acuity, I talked about how prevalent that is. Some simple tests, of course, we can look at an eye chart if you have an eye chart there. But also some simple things would be just having a newspaper or a magazine. Are they able to read the headline? Are they able to read the story itself? And if that is not, you want to definitely have a little bit more formal evaluation with a specialist. So as I mentioned, many individuals have those chronic eye conditions, which they will be followed hopefully by a specialist intervening with the treatments for that. We just want to make sure that that is a constant, that they're going to their appointments and that's really being addressed as much as possible. The hearing acuity, the whisper test or their finger rub test, pretty crude tests that can be done easily, just rubbing the fingers there right near the ear or whispering behind the person to see if they're able to hear. But also part of that assessment would be to actually look in the ears, because we have a lot of individuals who have decreased hearing due to wax or other things in the canals that we need to remove and ensure that they can hear. Referral to the specialist as well, audiology, to have that formal testing and see if an individual would be able to improve their hearing with hearing aids. Unfortunately, even with all the number of individuals with hearing loss, only about 11 to 18% wear their hearing aids. Most or even obtain hearing aids, and part of it is because Medicare doesn't pay for hearing aids and they're quite expensive. But also what I hear from a lot of individuals is that even if they do get the hearing aids, it's very difficult. They've adapted. By the time they've had this hearing loss, they've had it for a really long time, then they try to listen with these hearing aids, and sometimes altered sounds are there that are more problematic to them, and they possibly won't use them. So that can be really frustrating. Cognition and mood, the evaluation that we do there to just screen will be the mini mental state exam, the clock drawing, or a mini cog. Again, some screening tests just to give an idea of where the individual's cognition is. Mini mental state exam that takes a little bit more time, but it looks at orientation, word recall, some abstract, the clock drawing, it looks at executive function. So the mini cog just puts those together. Really quickly you can do a 3-word recall on a clock and sort of get an idea of how an individual is able to remember as well as problem solve with being able to abstract think on a clock. So again, those are screening. We can do more involved testing with neuropsychology referrals to get an idea of how well. This becomes very important if a person lives alone, because how well are they able to remember things and be able to accomplish things, especially those activities on the instrumental activities of daily living. We need to evaluate. When they have some caregivers and support, it can be a little bit easier to accomplish. Depression, really most common psychiatric diagnosis in the elderly. There are several screening tools. The geriatric depression scale is one. It's important to differentiate between dementia, depression. Memory loss and the inability to concentrate can be part of both. The highest suicide risk, of course, is those older males, white males, so we want to make sure that we're evaluating for this. So when we see all of these assessments and we see deficits in any of these areas, then we then want to point towards what kind of interventions. So here's some of the interventions that we can institute in order to assist individuals to age in place. So a home safety eval, some home modifications, some physical activity programs, the caregiver support, and then accessing community programs to assist them. So the key areas in a home safety eval, usually this is conducted by physical therapists. We call on them to go in and look at the home and assess for the safety. But these are the key areas where problems occur. Falls occur, a difficulty to get up and down. So we want to make sure that these are the areas that are looked at. Those stairs, the bathroom, the flooring itself, the lighting throughout the house, including over the stairs and outside of the house, and in the kitchen. How well can a person move around in the kitchen and be able to obtain what they need to in order to cook and eat. And then as well, usually physical therapy, occupational therapy will make recommendations for some home modifications to the family or to the elder themselves. So we have if there's a deficit in balance and coordination, especially if it's in the bathroom, that would be a high-risk area for falls or not being able to bathe. These are some of the things that we would want to have in place. The best bath seat and the bench, the grab bars. The handrails can be down the halls themselves if individuals are having difficulty going down the hall. Those just depending on how wide the hall is, they hold on to there. Phone in the bathroom is an interesting one in order for at least there be a way to call or not being tried to rush anywhere else. And then having that walk-in shower versus having to get into the bathtub to take a shower is another modification that could be looked at. If there's a hearing impairment, increasing the volume actually on the phone would be a simple one. They also have phones that have lights on them when they ring, so that also can be helpful. And then the smoke detectors can have a strobe light versus the sound for when it's going off for safety reasons in case of a fire. If there's a limited reach issue, then we can make some adjustments within where things are. Simple things like putting the rod lower in the closets versus way up high, having the cooktop, always looking for those controls to be in the front versus way in the back of the stove. Looking at having electric outlets that are higher, so you have to bend over so far in order to plug things in or have things plugged in. There are shelves that can be put in the kitchen that you can pull down and then have it more at a lower level to be able to look at versus trying to step up on things in order to be able to reach things behind. Those lazy Susans are an option also to be able to just move something around versus trying to reach. And then pull out shelves in the kitchen, the drawers as well would be helpful. If there's the limited vision, simple things like increasing the wattage of light bulbs, putting lights that are brighter in closets, or even some closets don't have any, having those lights in the stairwells, having the actual different colored tape on the stairs so they can differentiate that these are different steps, so it's not all looking the same. And then having those under the cabinet lights in the kitchen so that you can definitely see what you're doing on the countertops. If they're the poor strength of the hands and arms, as I mentioned, being able to have a D-shaped handle versus the finder handles on the cabinets will be helpful. Having the doors and the sinks having a lever, again, versus something that has to be manipulated in this way. Having push-button controls versus, again, the dials, because it's more difficult with those fine motors. The actual decreased mobility, range of motion is having things a little more easier with an elevated toilet seat. The carpet or the firm pad, making sure that it's low, so would decrease the risk of falls. Of course, the clutter we'd like to be remedied so that there would not be falls. The widened doorways for walkers or wheelchairs, a lot of that is more difficult to accomplish in the older homes. Not having area rugs, then there could be a ramp to the doorway with the handrails, and then that slip-resistant surface on the stairs, especially outside, lots of humidity. You want to make sure that it can be accomplished. Another intervention, though, that we utilize quite often is physical activity. We know that most individuals, not even just in the older group, are not regularly physically active. They don't get physical strengthening aerobic activity. As you can see, in 1998, it was only 7% of 65 to 74-year-olds were regularly physically active and involved in strengthening activities. Even less in the 85 and older group. And we did make some improvement in about a decade, but still pretty low numbers. So trying to get individuals in exercise programs of some kind, whether they're formal, specific to them like physical therapy or community type exercise programs, is one intervention in order to keep them mobile, functional, and being able to age in place. So physical therapy can be done in the home, outpatient clinics. There are walking clubs. People seem to be more successful when they have other individuals they're doing it with. Senior Activities Center. They get personal trainers, the local YMCA. We want you just to encourage individuals to make sure that that is a part of their everyday activity because it's so important to maintain their function. Caregiver support, when we have some of these deficits and we've made modifications and maximized strength, we still sometimes need assistance. So tapping into what support that the individual has is going to be important. Having social work who can help you with this as well, or with geriatric care managers who can assist is helpful in your multidisciplinary groups. The immediate family usually is the first ones you're dealing with, and a lot of them will provide total care or partial care, but trying to identify who are these members who could be able to maybe assume some assistance in order to have this individual stay at home and be functional if that's their desire. The extended family members, we want to tap into them, don't even realize, and we'll be happy to help if they knew what was going on. So looking at those informal caregivers, or again, when you utilize those individuals who are privy to the information of who are these informal caregivers out there. Students, church members, there's lots of individuals who will, for minimal pay or even no pay, be able to help out with some of these things that these individuals will need, the deficits. And then there are actual paid programs. You can hire someone to be able to do some of the assistance that's required. Preparing meals, taking people, transportation, lots of entrepreneurial groups are out there to be able to assist. And then when we're looking at actual community programs, again, having those involved with social workers, geriatric care managers who are real privy to these programs that are out. The Medicare, we do have home health, is the only federal, other than looking at VA, if you have a veteran, they have some programs that would provide monies to hire individuals to assist in the home. But home health would be a skilled need or physical therapy in the home would be covered under Medicare. The Medicaid program here in the state of Texas has the provider services, individuals who could be hired for a certain number of hours per week in order to go in and fix meals, clean, help make sure that they have their medications, do the shopping, things like that. So that's what they're doing. And then there's, again, the private groups. Many of the private can be covered by long-term care insurance. So individuals who have obtained that earlier in their life, then be able to utilize that for in-home assistance for that. And then there are some community programs. So if an individual maybe is really having some difficulty and needs some assistance in staying somewhere during the day while their loved one either works or does other things, we have some senior centers, day programs, things like that could, again, be able to still accomplish being able to age in place, but putting together some of these programs. Then we come to planning, because ultimately we know some of these changes will occur. We can do some preventative things to ensure that we maintain our function, our strength, but ultimately at some point assistance is going to be required. So being able to plan when younger, what would I want, how would I like to accomplish this, so that it's not have to figure out what I'm going to do. Being able to make these kinds of plans for staying at home, but then we come to a point where we've done all of these things. We've patched it together, we've done everything we can in order to have this individual age in place, but due to the cost or due to the deficits, we're not going to be able to still do that. What do we do then? So it's planning, where do we go from there? And that becomes then looking at our options outside of the actual home of the individual. Is it then going to a complex where they can then have that assistance but then move along at least in the same place as their function declines, or looking at each one separately? So we looking at relocation would be personal care homes, which are smaller facilities. They're actually a home with 5 to 16 people live in a personal care home. And then assisted living would be a little bit bigger facility, again requiring assistance, but being able to live in their apartment. And then we have the nursing home that requires a higher level of skilled care, that individual is fairly dependent in all of their activities of daily living as well as instrumental. And so we have Mr. and Mrs. Boomer, who've been married for 45 years. And Mrs. Boomer is 62 years old and suffers from type 2 diabetes, which has significantly affected her lower extremities. She has an above-the-knee amputation. Her right leg currently uses a walker and is prosthetic. However, a wheelchair has been recommended for the future. She also suffers from low vision, but enjoys reading, cooking, and with her husband and gardening. Mr. Boomer is overall healthy, primary caregiver to his wife. He is 65. He assists her daily with stepping in and out of the shower and getting on and off the toilet. Both have become very difficult. He also drives and assists her out of the house and into the car. He's always parked in the carport. He's a retired engineer and suffers from arthritis in his shoulders, knees, and back. The pain's most common in the morning when she likes to bathe. He enjoys cooking breakfast for himself and his wife, but his kitchen makes it difficult with reaching and able to sit at the counter. They live in a 3-2-1 story in downtown Orlando, Florida. The property value is $130,000 to $200,000, and theirs is appraised at $135,000. The home is located 2 blocks from the pharmacy, 3 blocks from the local grocery store and the city bus stop. There's also a walk-in medical clinic 1 block away that their primary care physician works. They've lived in their home for 30 years and raised their 2 children that are now grown and both living out of state. As a couple, they enjoy working out at the Y and participating in church activities both within a 2-mile radius of their home. So, here are some questions for thought. What are the family and the patient concerns for continuing to live at home? What would their own concerns be, or what would families' concerns be?
Okay, I'm going to open it up to the group. I'm going to put Monica on the spot and see if there's anything you want to relay.
Okay, well, I couldn't exactly remember which setup bathroom, but if they don't have a walk-in shower, here the area where I work, there's an agency that if you're 60 or older, they will help modify your bathroom to do grab bars, to do a walk-in shower. They also help with getting handicap toilets and raised toilet seats. That's an idea that I would have. Also doing some modifications to the kitchen to help with opening up drawers and cabinets, as well as we had the idea of getting a grabber, maybe to assist him if that's a problem. The husband has to care for his wife. And with him being a retired engineer, we felt like it's possible that he may have some money to where maybe he can hire somebody to come in to assist him, maybe even if it's not every day, a couple times a week in the morning where he's having the most difficulty with bathing his wife, just to come in and assist them. And if not that, maybe they could get some other kind of assistance with getting somebody to come in if they don't have the funds available, like maybe through a provider or something, will just help him when he's having the most difficulty with his arthritis in the morning.
Excellent.
Because we want to keep them at home. They live in a great location.
Great.
Excellent. We're gonna, Mark, we're gonna probably try to give each side a little bit of time and see if another side has some comments.
Absolutely. Did you hear us okay?
We heard you great. And we might go back to you if we have some more time, because I know you have more to talk about. We're going to try Baylor, maybe down in the bottom left-hand corner here. I see Jim. Hey, Jim. There's Dr. Eller there. He's off to the right. See him over there. He's right there.
I'm going.
Hey, Jim. What did you talk about?
Well, we didn't have a lot to react in it, but we didn't talk about some of the elements of the case. I keep asking for something profound, and nobody has anything for it.
Well, just like the other girls kind of focused on the home modifications.
Sure.
We didn't feel that they needed to do longer one where we felt they could stick it out where they are.
There you go. There you go. One question, something that I raised that the nurse might better handle. We're having trouble with arthritis in the morning. Is it possible to move some medications around in order to better facilitate early morning reduction in pain?
I'm sorry. What did you say?
If there's issues with arthritis in terms of early morning pain, in terms of your, how do you maybe some kind of alleviate acid, it's probably better.
Right. Yep. Recommendations for him in order to deal with his pain would be, the physical activity that he could do, maybe some medical treatments as well, but also sort of adapting. How can we make it easier so that he's not having to do such high-end activity at that time?
Hey Tony, this is Tom up in Wise County, and we had a discussion that included most of the things that have been covered by other people. However, I wanted to turn this over to Megan. She brought up a program, CBA, which might assist people. Megan?
Which I'm okay with. But so we kind of talked about, I'm a home health social worker. We talked a little bit about VBA and the wait list for that, and that it might be good to go ahead and make a referral for the Department of Aging and Disability Services for this family, so that maybe if things continue to decline and they really need some of those more intensive home modifications, they can have an allowance for that, and then the personal attendant services would also come through that Medicaid funded program. And then of course I think home health could be a good option, especially for the wife, because she's less mobile and getting to and from appointments and physical therapy and things like that would be more difficult. So I think that would be excellent. And then, you know, when I hear about case studies like this, I always think about long-term care insurance and how important it is to prepare for situations like this before you actually are in this position, so that you have some financial assistance in funding the care that you need whenever you get older. Because it would be too late for them to purchase long-term care insurance because they already have the diagnoses that would lead to needing these services. So that was about it. And then we talked about the potential of preparing them for assisted living, the financial planning in regards to that too.
Hi, this is Lamar University.
Hi.
We're hearing our conversation because we really identified a lot of what's already been discussed. I think one thing would be to help the husband see how he might prepare the night before for breakfast, you know, when he is feeling more comfortable and it's not hurting as much. He could fill the coffee pot with water and he could set out plates and try to think about preparatory work then. Also, it would depend on how much the wife weighed and probably how able he is to really assist her. And then we were discussing the idea of the walk-in bathtubs and wondering how well those really work with patients. So I don't know if anybody has experience with those patients who use those and how well they work, but that since he was an engineer, maybe they have the financial means to make some minor structural changes to be assisted.
Very good, Amy. Thank you. Good thoughts.
Well, in our group, Dr. Grumbles pointed out, we really need to start with what are the boomers' goals. Because they might be ready to move into or to downsize into an environment that's more friendly to their physical needs. They live in Orlando, Florida. There's got to be lots of options there versus living in some of the smaller communities that we have here. And then looking to reach the goals that the boomers have for themselves, then identifying the various interventions that everybody's talked about to, you know, if they want to stay in their home, educating them, discovering what are their financial resources. Are there modifications that need to be made now or in 6 months or a year as their needs change?
Yeah, because right now it seems like they have good resources. How will that change over time?
It'd be interesting to know also, we see this all the time, also family input. Ultimately, of course, it's their decisions, but they, of course, children seem to influence quite a bit. So it's involving them in that discussion can be really important. Yes, ma'am.
We were discussing the question that someone presented regarding the arthritis, and I think they mentioned something about whether or not his medications can be moved to that time of day. It sounds like since it's worse in the morning, he may have rheumatoid arthritis, which gets better as the day progresses. And so one of the options that they have may be to change her shower times to in the afternoon instead of in the morning. And that gives him an opportunity to kind of build up the strength, let his pain medication work, and that sort of thing. But we know that that's a debilitating illness, and within 10 to 15 years, it's going to become a lot more challenging for him. So in home, maybe a home health aide that can come in and help with their showers 2 or 3 times a week. I believe Medicare covers that, with them being over the age of 60. Well, she's 62, but that may be a longer range goal regarding that.
Good point.